Hello and good day to you. This is Tracy Harrison from the School of Applied Functional Medicine, and I want to invite all progressive healthcare practitioners into some commonly overlooked opportunities to better utilize lab data in order to help us to understand what are the roots of functional imbalance internal to a unique individual's case of disease, or perhaps to prevent a brewing, worsening of a state of disease. At the School of Applied Functional Medicine, we've been educating healthcare practitioners for 12 years now, and we have the distinct pleasure and privilege of having a community that includes over 22 different professional medical and health and wellness modalities, hailing from 75 countries around the world. And so you're all very welcome in your diversity. But I'm going to go ahead and jump right in because I have a lot that I want to talk about today. And in particular, I want to start off with just some encouragement, something we all know intellectually, but can be easy to lose sight of, especially as we are seeking to make our work as efficient as possible. And this is, of course, the fact that the vast majority of the lab work that we are running is, of course, a reflection on a certain physiological or biochemical state in this unique individual at one point in time. And we often can lose sight of just how labile, just how variable some of these markers can be, especially in response to what an individual is experiencing at the point of a blood draw. And many of us, of course, are well familiar with the fact that individuals can have a white coat, as we like to call it here in the U.S., type of reaction to the stress of a medical appointment or maybe a diagnostic encounter. Maybe they're nervous about what is happening about their health. And we often use this phrase, white coat reaction, in response to blood pressure. But the reality is there are a number of blood markers that can actually be skewed based on current or recent circumstances. And this is why I want to start off by simply talking about the notion of lab draw hygiene. Now we talk about, through the functional medicine lens, important concepts such as sleep hygiene and eating hygiene. And that is the circumstances around these everyday activities can make a huge difference on what actually happens downstream. Well, the same is true with regard to labs. Because, of course, when we are experiencing stressful circumstances in our human physiology, we know that blood pressure is not the only thing that is responding to the environment in order to help us weather stressful circumstances. We know that when our sympathetic nervous system gets activated and we are nervous and hypervigilant and stressed, we are perhaps fearful, we're uncertain. Well, these are the kinds of things that don't just happen from a primal sense when our lives are truly threatened, but they can also happen because we're nervous about something that's going to happen later on in the workday as we stop by the lab to get a blood draw first thing in the morning on our way to work. People can have all sorts of traffic accidents. They can have stressful family encounters. They can oversleep through their alarm clock first thing in the morning. But anything and everything that can contribute to a really stressful environment just prior to or coincident with a blood draw is, of course, going to skew a number of different values from that individual's norm. And while certainly some components of that can't be controlled, it's important to give your patients a good education about trying to get their blood draw on a typical day. Ideally, not a day right after they have just returned from vacation. Ideally, not the day after they've had some really traumatic or crisis event happen to them. Also, not perhaps a day in which yesterday they decided to get divorced or yesterday they decided to get married. These are atypical circumstances. that can be very stressful and can lead to misleading lab values. We'd like to actually get a blood draw or a salivary sample or a urinary sample on a typical day where we have undergone our typical circumstances. It's also important to teach people what you mean by first morning fasting labs. We talk about this all the time in our practitioner community, that individuals often believe that labs are fasting if they haven't had any solid food, but it's okay if they had a big vanilla latte. Or it's first morning labs or fasting labs if they simply haven't eaten anything. They got up at 6 in the morning, but they're having their lab draw at 2 o'clock in the afternoon. These types of assumptions can really dramatically skew their results. We need to teach people that first morning fasting labs, on which we depend for objectively evaluating so many different labs, means having consumed nothing but water for the past 10 to 12 hours. We need to spell it out. It's easy enough to put together a simple handout. At SAFM, this is a great example of a done-for-you patient handout or tool that we prepare for our students so that you can educate them in advance how to make sure that their labs are as objectively accurate against a first morning fasting normal as possible. And no, black coffee, a big cup of black coffee, is not a fasting state. Even if individuals don't put any sugar or creamer in it. So we have to teach them what to consider. There are lab markers beyond the blood pressure, blood sugar, total cholesterol. These are the types of things that can be elevated as a result of stress. Fibrinogen, high sensitivity CRP might also be elevated depending on the extent of the stress. If individuals did really aggressive workouts the day before, maybe they played some aggressive sports where they were really exercising strenuously the night prior, this can also have an impact on things such as liver enzymes or creatinine, these types of markers that are a reflection of muscle cellular metabolism. So again, we're looking for individuals to really use good lab hygiene in order to have samples that are as objectively normal as possible. So things to consider in terms of coaching your patients in advance and really teaching them how to partner with you in order to get the best possible data for understanding what is at play in their particular circumstance. Another item that is often overlooked is the importance of hydrating before labs. Many of us know how to look at a lab panel and see if dehydration seems to be at play. In particular, markers such as hematocrit and albumin, when they are notably elevated, are reliable indicators of dehydration. And in general, you will see a subclinical elevation in a number of different concentration-related markers in those states. And so we're looking for individuals, even though they are fasting, to still be drinking good amounts of water in order to help to ensure a good circulation and also good objective concentration markers. So just some important tools to think about. We also highly recommend that you teach your patients to not take any supplements in the 2 entire full days prior to the morning lab draw on the 3rd day. Now, you may be familiar with this, but if not, it's an important clinical tip right away. There are a number of supplements that can interfere with the accuracy of lab markers. And this is especially true through the functional medicine lens, where you may be checking on nutrient levels and this type of thing. But again, if we don't specify whether supplements should be taken or not, or for that matter, if certain medications should be taken or not, individuals are going to make their own choices. And even if people are fasting, they may still take a handful of supplements with a glass of water within the hour or two before they go and get their blood draw. Now, I want to give you one great example of this interference between supplements and lab assay accuracy. Biotin, vitamin B7, is one of the most notable culprits because it can directly interfere with the accuracy of a number of different markers. In particular, pretty much every marker inside a full thyroid panel. And this is of note because if individuals are in a hypothyroid state, they may be struggling in particular with hair loss or maybe with brittle or weak nails. These are two common symptoms of a hypothyroid state. And at least here in the US, it's quite popular for individuals to believe that a high-dose biotin supplement may help with those dynamics. Incidentally, it can help if a person is deficient in those nutrients. But taking these aggressive supraphysiologic doses of biotin to try and support hair health has not been shown to be clinically effective if an individual has baseline sufficiency of biotin. But the challenge is that biotin interferes with the actual lab assay. Biotin itself is not creating an abnormal thyroid state in the body of the patient, but the presence of this surplus biotin in the blood directly interferes with the accuracy of the assay that the lab is going to run, in particular for thyroid markers. And the worst thing is that it is not necessarily going to modulate the markers in the same direction and to the same degree. And so you want to be sure to, again, educate your patients we recommend stop taking all supplements for 2 entire days before they get a blood draw to avoid any of these assay interference nutrients and help to ensure the value of the lab data that you actually receive. And so an exception to this might be digestive support. Now, if individuals are used to taking maybe digestive enzymes or hydrochloric betaine, then certainly you would want them to continue to take those in the days running up to the lab draw so that they can be bringing on board the nutrients from their diet in a typical fashion. And then, of course, another exception might be if indeed an individual is taking supplements at nighttime in order to help with sleep. Because one of the aspects of normalcy that you would like all of your patients to have in the 2 days before a lab draw is sleep. When you have a particularly poor night of sleep, that is a form of stress. And next morning, your fasting cortisol levels, again, your blood sugar levels, your fibrinogen levels, there are going to be a number of things that are going to be elevated that can skew an individual's data from what their typical norm would be. So you'd really like to make sure that in the run-up to the labs, people are eating their typical diet, they are supporting their typical digestion, they are supporting their typical sleep. These are 3 aspects that are important to educate them about. And as I mentioned earlier, also ideally doing their typical movement and exercise. So we get a good normal look at what is at play. And so just some important aspects of lab hygiene in order to avoid interference. But so much easier for your patients to simply get a 1-page handout from you, guidance in advance on how to avoid these gotchas with regard to lab data utility. Now, I want to talk about some specific lab markers that you want to be on the lookout for and some of the common missteps that we see practitioners encounter. And I'm going to be speaking in particular about some fairly everyday typical lab markers that often we are either missing opportunities to use more fully in our case assessments, or we are interpreting them in ways that might actually be misleading. And I want to speak in particular to, first of all, the notion of using labs in order to understand what is at play that might indicate a particular drug prescription or a particular supplement recommendation. And the first one I want to mention, hopefully is not a surprise to any of you, but it's a gotcha we see at play in a lot of patient cases that we cover at SAFM in our practitioner community. And that has to do with iron. I can't tell you the number of cases in which we have seen individuals being given iron supplements, perhaps via prescription, perhaps via supplement recommendation, simply based on hemoglobin results, where an individual appears to have microcytic anemia, in particular if it's a subclinical dynamic, or even if their serum iron is subclinically low. On many occasions, a larger lab panel, or maybe an available lab marker that's simply not being looked at, holds important pearls that would make that iron contraindicated. And this is when maybe hemoglobin or serum iron is suppressed a bit, and certainly may be creating symptoms, but an individual's ferritin is notably elevated, as an indication of the fact that the body may be sequestering iron, perhaps away from vital functions, locked up in the storage form of ferritin, often in response to a notable inflammatory dynamic, in particular when there is a brewing infectious dynamic. I would think of this as the body's wisdom trying to protect a worsening of an infectious environment by preventing more ferritin from being available, which of course can fuel microbial growth. And so we always want to be running a full iron panel. If you're concerned at all about iron deficiency, and in particular microcytic anemia, be sure to run a full iron panel, so that you can really understand not just the status of hemoglobin or the red blood cell morphology, but also understand what is serum iron and what is iron binding and what is ferritin like in the body. In some cases, individuals may, for example, have optimal levels of iron, but hemoglobin is suppressed. Well, they don't need more iron. They may need help with the actual synthesis of hemoglobin, which in particular is affected by other cofactor nutrients, such as sufficient vitamin B6. Or maybe an individual's hemoglobin is a bit suppressed and their iron is a bit suppressed, but their ferritin is notably sufficient or even elevated. This can be because we are struggling to mobilize iron in the particular forms that are needed for other biochemical uses. This is where we need sufficiency of copper, in particular, in order to mobilize iron in the proper chemical forms, especially for hemoglobin synthesis. But it can also be, as I mentioned earlier, where there is a purposeful sequestering of iron, which helps us to understand that we need to help an individual to really get at the roots of resolving the infectious dynamic. And then the body, very often in its own wisdom, will allow more of that bound iron to be available for various biochemical conversions. But please beware of recommending iron simply because hemoglobin is suboptimal or simply because serum iron is suboptimal. We want to cast a bigger picture. Otherwise, we risk putting more of a critical heavy metal into the body. Yes, it's a nutrient element, but iron is the ultimate heavy metal as well that can have dramatic oxidative negative effects in the body. So we want to use great care when we are recommending iron, in particular in supplement form. Another common misstep is having a jump to considering statin prescriptions simply based on an LDL cholesterol result. And this points to the wisdom that we learn through the functional medicine lens about going upstream and understanding why might that LDL, low density lipoprotein, be elevated. And we remember that one of the most common reasons why it would be elevated in a woman is because she has a hypothyroid state. In particular, often a subclinical hypothyroid state that may have not been identified. It may have been completely overlooked, often because practitioners are only looking at thyroid stimulating hormone and assuming that that is sufficient to gauge intracellular thyroid hormone function. And nothing could be further from the truth. we need to really understand a full thyroid panel, and we believe that this is an important element of an annual physical blood panel for all women. Because when there is a hypothyroid state, even a subclinical one, what we often see is a slow or impaired uptake of LDL from the blood into the liver. And this leaves more LDL in the blood and therefore being measured there. But if we can remedy a subclinical hypothyroid state, LDL will often normalize completely on its own. And so we want to always be looking upstream and considering what is at play in creating this dynamic for this individual. It's also true that higher states of stress will often promote an increase in LDL. And sometimes that stress is episodic or transient in a person's life, and giving them an opportunity to address the stress or to simply get through the stressful period, and then reassessing the markers before we jump to a prescription that can have notable negative side effects in addition to the standard prescription purposes for LDL from an anti-inflammatory perspective. So we always want to be looking upstream, in particular checking what might be at the roots. But again, we see many cases of subclinical or even overt hypothyroidism where a woman has been recommended a statin medication when really what she needs is a deeper, more comprehensive look at her thyroid state and targeted support for optimizing her thyroid function, which usually will not only bring down her LDL to a more optimal level, but it will give her more energy, a better mood, and likely address a number of her other symptoms. And so we always want to do a full thyroid panel. Now, many times practitioners are shocked as they dive into all of the rich, complex case study that we included SAFM, and they see just how often individuals can have not only a normal, but a truly optimal TSH result. TSH could be 1.5 or 1.8 or even 2.0, right? Even what many people would agree is a functionally optimal number, even though the normal range is much broader. But when you run a full thyroid panel, alongside that seemingly optimal TSH, T4 and or T3 can both be not only suboptimal, but clinically low. This is not a rare outcome at all. And of course, we can't find a functional imbalance we're not looking for. And so it is not sufficient to assume that TSH is going to be even suboptimal, much less clinically high in all hypothyroid states. We believe and have seen through hundreds of case examples that intracellular hypothyroid function is a disease dynamic that may be one of the most commonly under-recognized, missed in clinical assessment. And obviously when it is left to persist year after year, with or without the checking of TSH, this is where women can begin in particular, because hypothyroidism is way more prevalent in women, can begin to struggle with weight gain, with increased body fat in terms of a shift in body composition. They can struggle with lower mood, greater fatigue, and all of these things can obviously lead to a whole host of other dynamics. A hypothyroid state can also promote dysmotility in the GI tract. It can promote suboptimal digestive secretions, maybe poor gallbladder emptying, these types of things that can easily set an individual up for a terrain that promotes IBS. And when IBS begins to become fueled over time, then we can also end up with nutrient malabsorption. And so by not catching a hypothyroid dynamic, we can kick off a cascade of progressive disease dynamics, right? And over time, 2 years, 3 years, 4 years, we can end up with an individual who is suffering mightily and struggling with some significant markers of disease that if we had 3 or 4 or 5 or 10 years earlier, if we had thoroughly assessed thyroid function, the opportunity to avoid all of that disease presentation was at hand and was simply overlooked. Another gotcha that I want to mention with regard to checking labs before jumping to drugs and supplements has to do with vitamin D, which is often recommended in either form without checking magnesium status. This is one we speak of often because magnesium is a common nutrient insufficiency in our patients and clients. It is a mineral that is less prevalent in our agricultural topsoils, and so it's less prevalent in many of our foods today. And because stressful states promote higher utilization of magnesium in stress hormone biochemistry and also promote urinary loss of magnesium, many of the people in our practices have suboptimal magnesium status already. Well, when you recommend to them a vitamin D supplement with a borderline or already deficient magnesium status, you will likely promote symptoms and dysfunction from overt magnesium deficiency. And this is because vitamin D metabolism in multiple stages requires magnesium. And so we can actually end up going from a borderline to a truly depleted status for magnesium simply because we've introduced a 5,000 IU supplement of vitamin D3. Even worse, 10,000, 20,000, how about that typical 50,000 IUs of vitamin D2 that is frequently prescribed these days in American medical practices? Then we should not be surprised when 3 days, 5 days, 2 weeks later, an individual starts complaining of symptoms of vitamin D toxicity. What they're experiencing actually is symptoms of magnesium deficiency. At SAFM, we teach to check and replete magnesium status before recommending vitamin D supplements in order to avoid this negative cascade. Similarly, we want to think about the fact that vitamin A and vitamin D in particular, as critical fat-soluble vitamins, are actually, with significant hormonal effects, are taken up in tandem in some of the oldest steroid receptors that humans have. And so by introducing a high dose of vitamin D, you can actually promote depletion of vitamin A as well. And while most of our diets certainly have not only a component of fully formed vitamin A or retinoid, they also include carotenes, which can be converted to vitamin A. But that conversion from those precursor forms of vitamin A to the final form are impaired in some individuals. They can be impaired genetically, and they can also be impaired where there are states of sluggish cellular metabolism. So, for example, for individuals who have a hypothyroid state or who may have insulin resistance. And so, again, just throwing in a large bolus of vitamin D, while that may be beneficial, we can end up creating some consequential nutrient depletions. So in particular, you want to think about repleting magnesium first and ensuring coincident sufficient intake, whether it's in food or supplement, of vitamin A when recommending vitamin D. And today I just have enough time to give you a few examples, but these are wonderful reminders that no nutrient acts alone, and that we need to learn where there are key critical nutrient cofactors that we want to think about as working in teams in order to fuel certain biochemical pathways. Other considerations for common medications, proton pump inhibitors and H2 receptor blockers that are also commonly prescribed for acid reflux. We need to keep in mind that those are busting digestion on purpose. They are creating hypochlorhydria, which by definition is going to impair digestion. And in particular, that lesser acidity in the gastric cavity is going to impair our ability to denature proteins and therefore isolate polypeptide chains so the digestive enzymes can be more effective. We need to do that in order for the body to readily ensure that it can digest and absorb the minerals that are usually attached to the amino acids in food. And with a lower stomach acidity, we also are going to have less effective binding of intrinsic factor to vitamin B12 to help to ensure its absorption further downstream. And so while an individual may be struggling with acid reflux, certainly at SAFM, we want to teach you to get to the roots of acid reflux, which is almost never someone having too much stomach acid. It's a common myth, it's a common assumption, but acid reflux is evidence of stomach acid in the wrong place. Many individuals who struggle with chronic acid reflux actually have hypochlorhydria, maybe for a variety of reasons. And so recommending a medication that further depletes stomach acid is not going to help them get at the roots of their unique case of acid reflux so that it can be made to go away. Certainly they may get relief from the medication, and that may be necessary depending on the degree of esophageal erosion that's taken place as a result of that burbling up of acidic gastric juices into the esophagus, and then the protein digesting effects of pepsin, which can be really damaging to the esophagus. But ultimately, we want to help people get at the roots of their acid reflux and actually make it go away. That's actually not that challenging to do through the functional medicine lens. But if a person, if you want to prescribe these types of medications, we want to be thinking carefully about ensuring that we're not going to create an overt deficiency of vitamin B12, because inadequate B12 can contribute to neuropathy, which many of our patients and clients already have. And if an individual has neuropathy, that can worsen their acid reflux. And so yet another example of where ongoing use of the medication can actually promote the very thing the drug was prescribed to do. We also want to think again about sufficiency of minerals like iron and magnesium and zinc and copper, these types of things that a acid suppressing drug can overtly interfere with our ability to well digest and absorb. In fact, here in the States, there's a formal warning about the possibilities of these medications creating magnesium deficiency. Another common prescription suggestion is metformin. Here in the U.S., it is standard of care for certain stages of metabolic dysfunction and type 2 diabetes. But metformin also has its negative side effects. And in particular, metformin can interfere dramatically with the absorption of vitamin B12 in the ileum, at the tail end of the small intestines. And it does this by interfering with the activity of a calcium channel. And so again, we want to check vitamin B12 status before you recommend metformin, because recommending metformin on top of suboptimal, much less truly deficient vitamin B12 status is likely to promote symptoms of vitamin B12 deficiency, including depression, anxiety, memory loss, ataxia, and neuropathy. And this is a real catch-22 because vitamin B12 deficiency already is at play in a number of individuals who have type 2 diabetes, because the elevated blood sugar, as we know, can do oxidative glycemic damage to nerves and promote, in particular, peripheral neuropathy. So that may already be at play, and then the recommendation of metformin on top of that, further depleting B12 status, can actually worsen diabetic neuropathy. So we want to think about checking some of these nutrient status markers before we jump to recommending a supplement or before we jump to recommending a medication. For that matter, I want to mention a few lab markers that practitioners may assume that we're measuring something that's bad, and therefore the lower the marker, the better, right? Well, not so fast. This is another common misstep. We're really passionate about teaching practitioners to avoid these common missed opportunities or even overt errors with regard to optimally using everyday annual physical lab work. One of them has to do with, for example, liver function tests, right? ALT, AST, or liver enzymes. We think about these as being negative markers if they're elevated, and therefore seeing a ALT being as low as possible in the normal range is desired, right? Well, no, not necessarily. And it's a great reminder of the fact that we always want to be thinking as we look at lab results, that these results make sense given what I know about this person. Now, a critical part to being able to do that is to see the person before you look at the labs. Too often we look at labs first. We reduce people to their social security number and their lab data. And we're trying to see the person through the lens of their lab data. And so we are not in a position with that shortcut approach to be able to question, whoa, hold on. This person has entrenched type 2 diabetes. It doesn't make any sense at all that their ALT is in the 10 percentile of the normal range. We don't want to simply wipe that away as saying, oh, good job, great, you must have good genetics, looks awesome. We want to question, wait a minute, this is illogical. How is it possible that this individual has these really low results when their lifestyle and what I know about them from their overall presentation does not associated with these types of results? And this is a great reminder that, of course, all biochemistry in the human body runs on micronutrients. And the things that we want to measure in lab data, lab draws, require nutrients for their synthesis. And if the body is lacking optimal levels of nutrients, then we're not going to be able to synthesize those biochemicals in an objective way that allows them to be reliably used as a marker of certain types of dysfunction. And a really commonly overlooked example is the importance of vitamin B6 in the synthesis of a number of critical enzymes in the body. And if you have suboptimal vitamin B6 status, then key enzymes such as ALT and AST might be suppressed in the body, and they may actually be quite low. They may be well down into the first quartile, typically in the bottom 10 or 15% of the normal range, and especially when, again, that doesn't make sense in the context of the individual whose data you are assessing. We know that many people with even subclinical levels of metabolic dysfunction often struggle with some aspect of fatty infiltration of tissue, including the liver. And this often leads to increased levels of turnover of liver tissue, which is actually a good, healthy response because it's evidence of the liver repairing itself. And if we know they have metabolic dysfunction that would already be challenging the liver, we actually want the liver to be repairing itself. The worst case actually is to have those disease-promoting states at play and to have the liver's ability to heal itself suppressed. In which case, not only are those low liver enzyme markers not indicative of a positive state, they're actually keeping us from seeing potentially an alarming state. And this is where promoting, say, optimal levels of B vitamins might actually enable those ALT levels to come up to where the body wants them to be. And so we want to be careful to not jump to the conclusion that just because something supposedly bad or negative as a marker is low in the body or low in the data for a given person, we don't want to assume that's a good thing. A classic example we often see in cases at SAFM are where an individual is using a SSRI or a woman is using oral estrogen-containing medication. both of which can promote really aggressive use of vitamin B6 that can actually lead to depletion of a sufficiency of vitamin B6 in their body. And so this can lead to challenges with regard to having adequate B6 for synthesizing these enzymes. So we want to be looking for this type of thing. Another great example of a often misinterpreted lab marker is homocysteine. We know that markedly elevated homocysteine can be an independent risk factor for cardiovascular disease. Elevated homocysteine can promote the incorporation of atherosclerotic plaque in arteries because it can actually promote oxidative damage to the endothelial lining of our arteries. But many practitioners are not thinking about what are the concerns about overly low homocysteine. What might be an indication of? And it's a great example where, once again, the optimal state in the human body is one of balance. We want to have enough homocysteine in order to fuel the critical biochemical pathways that are downstream from homocysteine. Like so many other things in the body, like liver enzymes, like cholesterol, homocysteine is not evil. It's not this toxic waste product that we want to be zero in the body. There's a lot of myths about that in progressive healthcare. But homocysteine is, while it can be disease promoting if it is elevated, it is actually an upstream precursor for the transsulfuration pathway in human biochemistry. And we need homocysteine in the body in order to make taurine, which is an essential amino acid for supporting biometabolism, for supporting GABA-glutamate balance and nervous system health, and supporting the synthesis of hydrogen sulfide, which is a really critical gasometer in the body. We also need homocysteine to promote the synthesis of glutathione. And glutathione, as many of you know, is the most important intracellular antioxidant. And as we age, and certainly something we've learned through the pandemic, as individuals struggle with infectious states, and especially with viral load or chronic viral load in cases of long COVID or post-COVID, our glutathione status can be markedly depleted. And so we need sufficient homocysteine in order to fuel these downstream pathways. And so we want to be concerned when homocysteine is too low, and in particular, 3 or less may actually be indicative of a case where an individual is struggling with an inability to create that downstream biochemistry. That's a situation where you want to be checking, for example, for glutathione sufficiency to make sure that that homocysteine is not depleting those downstream critical needs. And where an individual may actually not have enough homocysteine, and fueling the methylation pathway may be really important for them. Things like fasting glucose, right? What about when an individual is eating a standard American diet that is rich with refined carbohydrates and sugars, and we see their fasting glucose is seemingly optimal at 84. And so we think, oh my gosh, awesome, it's great, everything looks fine, keep doing what you're doing. Well, that's misinformation. It's a missed opportunity. In those types of situations, we should be thinking, wait a minute, this isn't logical. If an individual has been eating this type of diet on an ongoing basis, how is that possible? Well, 2 of the most common circumstances in which you might see an optimal fasting glucose data point in the context of likely metabolic disease is in a state of hyperinsulinemia. And it's a great reminder of the fact that in early stages of insulin resistance, blood sugar is not going to be changed at all initially, But during a nice long period of time, during early and even moderate states of insulin resistance, blood sugar is going to be lower, not higher, because the pancreas typically responds with an adaptive hyperinsulinemic state that anticipates the aggressive glycemic load of this individual's lifestyle, and it ends up driving blood sugar down lower, especially when in a truly first morning fasting state. So that low or seemingly optimal fasting glucose does not at all mean that a person does not have brewing metabolic dysfunction going on behind the scenes. And we want to catch that. This is why we recommend that fasting C-peptide, ideally, or at least fasting insulin, be a component of an annual physical lab panel, because we need to evaluate fasting glucose alongside insulin markers, such as fasting C-peptide, which is a little less labile than fasting insulin, but also alongside hemoglobin A1C. Because even if the person's insulin is optimal, which I'll get to in just a second, what if they have low levels of cortisol? What if they have an exaggerated chronic stress state and their HPA-TG axis has created a hypoadrenal state? And so their first morning cortisol is not optimal at all. It's low. This is one of the primary determinants of first morning fasting glucose. And it's one of the reasons, by the way, why you can see side by side an individual may have a fasting glucose, again, optimal, maybe 84, right? But their hemoglobin A1C may be overtly indicative of prediabetes or even entrenched type 2 diabetes. Yes, you can have a fasting glucose of 84 and a hemoglobin A1C of 6.3. So this may simply be true overt metabolic dysfunction alongside a hypoadrenal state. So we cannot rely on low or seemingly optimal fasting glucose values as being desirable. Again, we want to stop and think, who is this person? Who have I learned this person is who's presenting with this lab data? See the person first, then look at their labs. You are way more likely to actually identify the roots of disease and dysfunction in their unique case so that you can help them to truly resolve their disease states and create raving fan patients who can't wait to give you amazing testimonials and refer their friends to your practice. If we try to see the labs first and reduce people to being a number against a statistical normal range, we're highly likely to miss dramatic brewing disease dynamics that are only going to worsen within a unique person while we're not looking for them. Now, I want to come back to fasting insulin because that's another often missed opportunity. This is one of the best examples of the fact that the typical normal range is not a target range. For the vast majority of lab markers, at least here in the U.S. Now, this varies by country, so you want to get educated on what the precedent is, not only in your country of practice, but also for the labs you use. In the U.S., the vast majority of normal ranges are statistical norms. So it is simply 2 standard deviations from the average within a patient population free of a formal diagnosis. Now, we all know that normal ranges are full of people with functional imbalances that simply haven't been assessed sufficiently or haven't gotten worse enough to be diagnosable. And what this means is that the normal range is not a target range. It's certainly not a healthy range. And there can be a really dramatic difference between what is normal distribution and what is an optimal zone. And so we need to teach people about this distinction, and we need to get truly masterful about using these types of optimal zones ourselves, because otherwise we're going to be missing a lot of opportunity. Speaking specifically about fasting insulin, it might surprise you to learn that at least the upper 2/3 of the normal range of fasting insulin is likely indicative of insulin resistance. Again, evidence of that slow, steady, adaptive increase in fasting insulin as the pancreas tries to accommodate an excessive glycemic load in order to prevent those negative oxidative effects on the body. And hyperinsulinemia can be often diagnosed for years before there is enough dysfunction in the body to actually start to create pancreatic insufficiency that leads to elevated blood sugar. There are wonderful studies looking over years of assessment indicating that individuals can have overt insulin resistance 13 or more years before they actually receive a diagnosis. That is a lot of years in which people are being told, you're fine, you're good, your labs look great, see you next year. Everything looks normal. Well, here's the challenge. We may use the word normal to mean statistically average, but your typical patient hears the word normal as fine, acceptable, healthy, like everybody else. You may not use those words, but in the absence of your clarification and you teaching them otherwise, they're going to infer that when you tell them everything looks normal, that is for them a message that they should keep doing what they've always done. It's a message that they should simply move forward with the same behavior because they're not doing anything that you believe is promoting disease. Now, that is a really important association to think about, because when we miss opportunities to point out to patients during annual physical appointments, or when you maybe as a complementary practitioner have a chance to look through their labs and teach them about what is at play there that might be different or more expansive from what they receive from their primary care provider. Well, this is a powerful opportunity for people to learn that their behavior is promoting dysfunction in the body, which often is not severe enough to be diagnosable for many years before it worsens to the point of causing overt or debilitating symptoms and can be diagnosed. Because most of the diagnostic thresholds have to do when a dynamic is bad enough to be an appropriate candidate for a specific allopathic solution. But functional imbalances can benefit from so many different other diverse interventions years before an allopathic solution might be indicated and or necessary. And so we want to really learn richly to look at a mid-normal fasting insulin and consider that this is evidence of insulin resistance. And if the data isn't available, thinking about assessing a fasting glucose and a hemoglobin A1C, and perhaps they might be markedly lower than you would expect given their diet and their lifestyle. And it's a chance to work with them closely to help them to identify high glycemic load promoting habits, which can certainly be about food and beverages, but it can also be about a number of other lifestyle choices, especially ones that promote higher levels of stress hormones, which promote blood sugar, as we know, completely on their own and completely separate from diet, which is why individuals can have a seemingly perfect diet, even a low glycemic or a low carb diet, and they're active physically, but they still have brewing insulin resistance because of their level of stress hormones. And so we want to get in front of these types of dynamics. And when we assess them, we can recommend what specifically is going to make a powerful difference. I want to mention a couple of other markers I want you to be sure to be able to respond to starting right away. When we talk about inadequate nutrients, many individuals have subclinically low alkaline phosphatase. Alkaline phosphatase is an enzyme that is produced intracellularly, and it spills to a small degree into the blood from a few different tissues where it's prevalent. And we're used to the notion that when there's excessive alkaline phosphatase, this can speak to blockage or congestion within certain tissues that is promoting excessive spillage of this enzyme into the blood, such as when there's hepatic biliary congestion, and there may be biliary stasis, poor gallbladder emptying. And this can be a really valuable marker in the context of others corroborating data as well. But what about when alkaline phosphatase is lower than you expect? Well, once again, we have to think about what are the nutrients that are involved in this synthesis. And there are a number of nutrients involved in synthesizing alkaline phosphatase, but research shows that when it is clinically low or suppressed down into the bottom 15, maybe 20% of the normal range, we want to question whether or not insufficient zinc or insufficient magnesium may actually be holding down that marker. Now, that does not mean that there isn't some congestion or blockage within another tissue, but we need enough nutrients to produce objective levels of that biochemical so you can use the marker for the purpose you've learned that it's valuable. Otherwise, we're leaning on a marker as being valid when there's not enough nutrition to make that marker useful. And this is where, again, the easiest way to identify these gotchas is to see the person first before you look at the labs. And by mastering a good understanding of what some of the common nutrient depletion drivers are for these biochemicals, you can be much more effective in maximizing the value of fairly everyday, easily accessible markers within your clinical practice. But I want to say just a little bit more in particular about what to look for from an overall annual physical lab panel. At SAFM, we teach that there is value, especially in the typical American culture or Western culture, of checking every adult patient on an annual basis for metabolic function. And we recommend, and again, that include not only fasting glucose, that's typically part of a CMP, but also hemoglobin A1C and fasting C-peptide, or if that's not available, then fasting insulin. Or is this all that we ever need to assess in order to gauge metabolic function? Of course not. But we absolutely, by looking at these three markers on an annual basis, can help to assess and identify and help to improve or reverse metabolic dysfunction before it becomes more entrenched and necessitating some of the more involved glycemic assessments in the future. As I mentioned earlier, we also highly encourage the assessment of a full thyroid panel for adult women. We recommend that this include at least TSH, free T4, free T3, and both, not just one, but both thyroid autoimmune antibodies. Ideally, you also include reverse T3 and potentially also total T3 in that marker, so you have a sense of some other more advanced dynamics that can be at play in creating a hypothyroid state behind the scenes. But again, so often disease worsens because a hypothyroid dynamic is at play, and we can't find what we're not looking for. And so running this panel can help get in front of an awful lot of other dysfunctions. And it is true that a hypothyroid state promotes the risk of insulin resistance, and an insulin-resistant state promotes the risk of a hypothyroid dynamic. And so simply assessing these two things on an annual basis with a handful of lab markers can make a huge difference in enabling you to be a more proactive practitioner, and one that is able to look with a keener eye at identifying and addressing brewing disease dynamics before they worsen. And ultimately, isn't that why the patients come to you on an annual basis, not just to learn that something entrenched has appeared out of the middle of nowhere, which almost never happens, right? Insulin resistance doesn't appear out of the middle of nowhere. These dynamics are developing frequently over years but at least over several months, but most typically over multiple years. And we simply are not finding them in their brewing more subclinical states because we are not necessarily looking for them, or if we are looking for them, we are requiring that markers be outside of the statistical normal range before we say they're of note. And we are missing a huge opportunity to have a much larger clinical impact on the people you're passionate about serving by taking that particular approach. So a couple of other just small pearls I want to give before we close. I mentioned earlier a hypoadrenal state, right, where you are seeing that confusingly or surprisingly lower fasting glucose given an individual's metabolic state or their diet or their stress state. Another way in which you might see this at play is with electrolyte skewing. We remember that it's actually the adrenal glands and the kidneys that in tandem are regulating electrolyte levels in the body in response to our environment. And in addition to being affected by our dietary intake of these key minerals, we purposefully have different electrolyte levels when we are in a stressful state, right? When we are promoting a sympathetic nervous system mode where we're fighting, flighting, and hiding, as opposed to one where we are calm and relaxed and we are focused, the body is able to focus on healing and fertility and rejuvenation. And so individuals with a hypoadrenal state with lower levels of cortisol and lower blood sugar often end up with lower levels of aldosterone. And this can lead the kidneys to have lower levels of sodium and notably elevated, maybe not clinically elevated, but subclinically elevated levels of potassium. And this can lead to this cluster of notably low blood sugar, notably low blood pressure, and their pulse may actually be really not representative of their actual state of fitness. And so these metabolic markers can show up and should be a red flag for you to consider whether or not an individual has a hypoadrenal state, which can be fine if it's temporary as a state of healing on the other side of a really stressful period of time in their lives, or maybe in recovery from an infectious disease. But when it has been ongoing, especially longer than a year, this can often create a chronic state where an individual starts to struggle with highly debilitating fatigue and loss of stamina. And so again, sodium and potassium, really simple markers on metabolic panels that are available, easily accessible for the vast majority of our practices. And so we don't want to miss out on the opportunities to really glean maximum data. So I'm going to stop here for today, but this is just a tiny sample of what we are passionate here at SAFM about teaching healthcare, medical, and wellness professionals in terms of that devil in the detail know-how of how to maximize your clinical capability and your clinical confidence so that you can avoid or reverse, remove as much disease as possible. It's also a really powerful way to build your practice, because when individuals get a much keener eye and a proactive eye on their health goals and on their brewing states of disease than they have been able to receive elsewhere, they naturally are grateful. There's reciprocity that so often motivates them to give you wonderful testimonials and also referrals that can be really powerful business builders for your practice. Thank you so much for joining us. Have a great day.